attachment point. So that's the reason for getting to know them.
The ones in bold, right?
Yeah. Yeah.
And then are we going to be responsible for knowing like all the synergists and things like that?
And maybe a couple of questions on those. And definitely there will be matching set of questions about two actions of muscles.
Okay, thank you.
Question also about, just going through today, like looking at like the superficial layers versus the deep layers of the hand muscles.
Yeah.
Would that be kind of something that would be specific, like this is a superficial muscle of the posterior hand and have an arrow to something?
No, I don't ask questions like that.
Okay.
Yeah, the only time that needs to be set up with the students is when we have an in-person lab and when we need to show these things on the cadaver. Yeah. And also, if it happens that we have a new cadaver in the lab and we start to get the students to do some of the dissections, that's the time when I need them to know all those layers. Okay, let's see. See if this works.
Oh, and then sorry, Professor, to interrupt. But just a side note, I'm on my brother's computer, so this is Alyssa, but I'm gonna come up in the like class today as Chase Tanner. So just so you you don't kick me out.
Fine.
Professor, for
Yeah.
muscle N on this one, for the biceps femoris, will you want us to specify exactly if it's like the long head or the short head? Or just say just like in general, the biceps femoris?
Oh,
Because I know that N, that's the long head. That's like what I put. So I was just like,
that part is just for you to identify the muscle.
Oh, okay.
Yeah, and then for the filled in part is where you would need to put in those origins.
Oh, okay, okay, okay.
Okay.
Professor, does the sartorius muscle also do abduction or adduction?
I don't go with that very much. Okay, the book says it, and that has to do with after flexing and laterally rotating the thigh, the knee is going to go outwards. So that's the reason they refer to that as abduction. But
Got it. So would we not have to count that in the essay question involving like abductors and adductors?
yeah, I don't, doesn't matter to me. If you follow the book, I don't mark you wrong.
Okay, thank you.
Yeah. But mostly that's the reason I don't mention that as much, because after flexing the thigh and then laterally rotating it, it's not quite the same as actually abducting the femur. With the muscles that actually abduct the femur, they actually swing it all the way out. The whole bone going out. So Okay. Um, yeah, at some point, check into Canvas. Okay. A few things have changed there.
Professor, too, I'm not sure, I haven't checked the changes, but I shot an email curious about the lab practicum, considering we haven't done the digestive and respiratory system. The due date is July 3rd, and we won't have covered that material. So do you want us to submit all the other ones first before we cover it, or we're gonna wait? Or was that one of the changes?
You should still be able to get through. Yeah.
So I'll still be due on the 3rd.
Yeah, get them all in. That way, you will be able to figure out what's going on. When I go through, most likely on the third date, on 3rd July. Let's see. Oh, yeah, get them in by that time. Okay. Okay. All right. Continuing with page 8A.
Professor, your screen's pitch black with a little bit of muscle from the pre-lab. It's not the screen I think you're trying to share.
All right. Okay. Getting through the posterior compartment in the leg. So the two major muscles that you would be sensing there as part of your calf would be the gastrocnemius and the soleus. There will be some other muscles that are somewhat deep to them and slightly medial. So for gastrocnemius, you are dealing with a muscle that has the two heads. And I don't go with your textbook listing on the origins. Your textbook simply refer to the origins muscles that would have the ones that you're in your textbook. It's going to say by two heads from medial and lateral condyles of the femur, and I do not agree with that. Okay, the two condyles of the femur are totally inside the synovial joint. And this muscle doesn't have anything inside the synovial joint. Okay, that's why you need to go with the epicondyles of the femur. Okay, so the two origins, posterior, medial, and lateral epicondyles of the femur. Insertion is at the very back of the calcaneus. That's the tuberosity. And this one has two actions because it crosses two joints. This is the one that would do plantar flexion of the foot. And it would also do flexion of the knee. And this is where I need to get you to understand why. So you remember the actions of those three hamstrings. They hyperextend the femur and they flex the knee. And you also should remember that their tendons of insertion needs to come across this joint before reaching the tibia as well as the fibula. So this means those tendons of insertion curve around these two condyles of the femur. So when you have a full extension of your leg, as well as using your anterior muscles here to dorsiflex fully extended and the foot is dorsiflexed, those three hamstring muscles would not be able to flex the knee because the direction of pull would now be out here. Because the tendons are curved around here. So all those sets of fibers would not have the focus point at the insertions. So they cannot flex the knee. At that time, you would depend on the gastrocnemius to bring the knee, start the flexion of the knee. Once it's flexed, so that the cell fibers here would have the direction at their insertion points, then they would take over, flexing that knee. So that's to get you to fully understand the actions of gastrocnemius. So make sure you know both of these actions. Okay. This is the one that would be plantar flexing the foot. Okay. Plantar flex is toes down, heel up. You can also flex the knee. I never bother using that term that your book now introduced. Previous editions, they didn't use that term. They're referring to the collective name for these three muscles: the gastrocnemius, plantaris, and soleus as triceps surae. So I just stay with the specific names of these. So soleus is the one that is deeper, and the origin is at the proximal part of the tibia, as well as the fibula, and also interosseous membrane. So that's soleus. And then it's going to continue into the tendocalcaneus. Okay, that's a term for this tendon. So the insertion is also tuberosity of the calcaneus. Yeah, that's the the name of that common tendon here for all three of these muscles. And if you want to go with two terms, then calcaneal tendon, which is to write in just one term, tendocalcaneus. So this one would only do plantar flexion. Okay. Plantaris is one of those muscles that I never deal with. In the lab is when I more or less lift up on the gastrocnemius, so students can actually see that tendon. That's the tendon of plantaris. Hardly ever show them the body of that muscle. And that's because in order to see that, you have to cut away all of these needs to be cut away before you can see that. So the plantaris origin is posterior femur at the lateral epicondyle. And then after those fibers has gone beyond the joint, then you'll send this long tendon swinging lateral. And then once it gets to somewhere around here, it's going to fuse with the tendocalcaneus. So insertion again is tuberosity of the calcaneus. And definitely this is a very weak muscle, but it may help the gastrocnemius in flexing the knee. Okay. But you do a little bit of weak action in plantar flexion of the foot.
Professor,
Yes.
why don't we call it gastrocnemius? Why do we call it the calves?
Gastrocnemius has to do with the two bodies here. When you use the term calf, you have a whole series of muscle back here. Okay.
Okay. Thank you.
And then, when your book used that term, triceps sirri, Sere in Latin has to do with the calf. But there are other muscles. Okay. So once you get through with those three, popliteus is the muscle that is totally in the back of the knee. And also that's another one that I don't handle. To get to it, you have to totally cut away everything here. So that's a muscle, popliteus. Popliteus, lateral condyle of the femur, well, lateral epicondyle of the femur. And then it would insert onto the proximal tibia. So mostly it's the one that's going to be flexing the leg and help to rotate the leg medially, especially when the knee is at full extension. Okay.
Professor, can I ask you a question about the soleus?
Yeah,
So that's considered part of the calf also?
it is.
Okay, and when we stretch like our calves and do calf stretches, is it also stretching the soleus or mostly only the gastrocnemius?
You'll be stretching both of them.
Okay, gotcha.
And soleus is definitely the red muscle. And that's the it's the postural muscle. That's the one that allows you to stand for a long time or walking long distance without tiring.
Thank you, Professor.
All right. Then we get to these ones. Tibialis posterior. Yeah. So for tibialis posterior, okay, let's see. It should be number 48. Number 48. No? Interesting. Then let's try 21. Yeah, 21. 21 is the origin for tibialis posterior. And it's going to be going over the proximal portion on the lateral side of that tibia, as well as a little bit of the posterior head of the fibula and the interosseous membrane. Insertion has a whole series of insertion, okay? And your textbook doesn't even set them up. So 21 down here, it's going to have the spreading of the tendons of insertion going to the bottom of navicular, all three cuneiforms, and then metatarsal 2, 3, and 4. Okay.
Can you repeat that, Professor? Sorry.
Yeah. So it's on the bottom of the foot, okay? Navicular, the three cuneiforms, so medial cuneiform, intermediate cuneiform, lateral cuneiform, and then the basis of metatarsals 2, 3, 4. This is the one that is a prime mover for your foot inversion. Inverts the foot. Okay. It would also do some plantar flexion of the foot. Okay. Flexor digitorum longus. That's right. So flexor digitorum longus, it would simply, right here, number 48. Okay. So that would be the one-third part of the midshaft. And then those tendons would split into the 4 items. That is going to insert into, okay, here's 48. And they'll all be at the basis of the distal phalanges, 2, 3, 4, 5. This is the one that would be doing 3 actions. Plantar flexus the foot, can also help invert the foot, and then it will flex the toes. That's how your book go after that. Yeah, we can go with that. Seldom ask these ones because it takes a lot of time to expose these things under the foot. There are at least 4 layers of material after removing the skin at the sole of the foot. So similarly, it would be flexing the distal interphalangeal joint, proximal interphalangeal joint, and MTP joints, 2 through 5. And then finally, flexor hallucis longus. Yeah, this one is coming from the mid shaft. Well, middle portion of the fibula. And interosseous membrane. And then it's going to go all the way to the base of the distal phalanx 1. And this one would also be plantar flexing the foot and flexing the hallux. Right. Okay. So that takes care of most of the muscles I go with my students in this course. All right. Continuing with the start of the digestive system. So just a quick review of the body cavities that we'll be dealing with. The dorsal body cavity, we'll be dealing that when we get to the nervous system. Okay. And so now we are going to be dealing with the ventral body cavity. Ventral body cavity, you have the thoracic cavity and you have the abdominal pelvic cavity. So eventually we'll be going through the abdominal cavity for the digestive system, mostly going through here, as well as the oral cavity. And then when we get to the urinary system and the reproductive system, we'll be handling a few more items in the pelvic cavity. So,
Professor, do we have to know those muscles for the reproductive system?
no.
Okay, thank you.
Now, we'll be going over this picture in a lot more detail. We get to the respiratory and circulatory systems. Just to give you an introduction of this, okay. So for the thoracic cavity, definitely you would still have an item that belongs to the digestive tract that needs to go through here, and that's the esophagus. Okay. The thoracic cavity. This one is something that your book never mentioned. Intrapleural cavities. Intrapleural cavities is those spaces that's been occupied by the two lungs. So in the lab, if we take away a lung, then you see a huge space here. That's intrapleural cavity. Pleural cavity is just a potential space. Okay. The pleural cavity has to do with, at the beginning, you have the parietal pleura that is lining the internal wall of the thoracic cavity. And then when the lungs started to move in, it would then be reflecting onto the surface of the lungs. Once there, there'll be the visceral pleura. So that means there will be a potential space between those two layers. So between parietal pleura and visceral pleura, you have the pleural cavity. It's just a potential space. Usually it's maybe about just 1 millimeter, and it will be filled with serous fluid there. Okay. Thin film of serous fluid. Mediastinum is the general term we use for this part. It's a subdivision of some of the spaces in the thoracic cavity. There are several other parts of that. The heart and some parts of those major blood vessels that would be attached to the heart would be within the middle mediastinum. That's what this one is. Middle mediastinum. There's an anterior mediastinum, and that has to do with the material that is between the back of the sternum and the pericardial sac. Posterior mediastinum has to do with this whole series of material here, depending on what level you slice across. Okay, at that level, that's what you see. If you slice it a little bit higher than that, then you would actually see the trachea here. Behind the trachea, you have the esophagus, as well as the thoracic aorta. In addition to that, there is the inferior mediastinum and superior mediastinum. Okay. We'll deal with that a little bit more when we get to circulatory system. Pericardial cavity. Again, we're looking at some of the membranes. Part of it had formed attached to the pericardial sac, and then when the heart start moving in, it would be reflecting around the heart. So again, you build up that pericardial cavity between those two. And we'll go through these ones in detail when we get to the circulatory system. So for the abdominal pelvic cavity, mostly we're just focusing on the abdominal cavity at this point. So the lining of the internal wall, parietal-peritoneum, and then when many of these organs that actually pushed in, then that